Assessment of mitral stenosis by echocardiography. Right panel shows the parasternal long axis view. Doming of the anterior mitral leaflet is seen well and has the appearance of hockey stick. This appearance is classical of rheumatic mitral stenosis. Paradoxical movement of the posterior mitral leaflet is also visible. Normally, posterior mitral leaflet moves posteriorly in diastole. Here there is a paradoxical anterior movement due to commissural fusion. Left atrium is dilated. Left panel shows parasternal short axis view. The mitral orifice is seen within the cross section of the left ventricle. The anterior and posterior leaflets are seen in cross section and are thickened. The commissures are fused. Parasternal long axis view will give an assessment of the subvalvar apparatus. Subvalvar fusion may result in poor results after valvotomy as they can produce secondary obstruction beyond the valve. Parasternal short axis view is used for quantitating the severity of mitral stenosis by using planimetry to measure the mitral valve orifice. Commissural fusion and calcification, if present, can be seen well on parasternal short axis view. Transmitral gradient is better assessed in apical four-chamber view by Doppler. Associated tricuspid regurgitation, if present, can be seen on apical four-chamber view, which will also help in estimating the right ventricular systolic pressure from the TR gradient. Parasternal short axis view in mitral stenosis showing the fish mouth appearance of the mitral orifice in cross section. Normal mitral valve cross section for comparison showing anterior and posterior mitral leaflets widely separated. Scallops of mitral leaflets are also visible more clearly in the posterior leaflet. The leaflets of normal mitral valve are thin, pliable, non-calcified and open well in diastole with valve area of 4 to 6 square centimeter. Opening of a normal mitral valve may be reduced in low cardiac output states even without significant mitral stenosis. Echocardiogram in mitral stenosis showing commissural fusion. Parasternal short axis view showing mitral valve in cross section and anterolateral and posteromedial commissures. The valve leaflets are thickened and the commissures are fused. The cut is slightly oblique as a good cut should appear circular. It is often difficult to get a good circular outline of the mitral valve due to varying anatomical features of the chambers and cardiac position. Ideally, the smallest full circle should be taken to planimeter